So my name is Hedda Hoel. I'm a PhD student in Marius Strøseid's group, and thank you for letting me present the results from our newly published paper, Elevated Markers of Gut Leakage and Inflammasome Activation in COVID-19 patients with cardiac involvement. Next slide, please. So the outline of this talk will be a little bit about the background and cardiovascular involvement and gut involvement in COVID-19, a few words on inflammasome activation, and then I will present the main findings from our study before I conclude. Next slide, please. As we're getting too familiar with, COVID-19 is impacting people all over the world, and this was from last week. Now we're up in 54 million cases and more than 1.3 million deaths. And even though really good vaccine news is coming out, it's important to elucidate the mechanisms in order to find treatment and understand the disease of coronaviruses better. Next slide, please. So, the disease presents in various ways, but can roughly be divided into 3 stages, where stage 1 is characterized by mild or asymptomatic symptoms, but with quite high viral titers. And in this phase, it can also transmit to other patients. This is why it's become such a pandemic. As opposed to the earlier coronavirus outbreaks, SARS-CoV-2 can also transmit from asymptomatic patients. Moving on to stage 2, which is the pulmonary phase with hypoxemia, and then some patients move on to stage 3, which is characterized by hyperinflammation, cytokine storm, and secondary organ involvement. Next slide, please. So early on, researchers from Wuhan early this year reported that patients not only had respiratory symptoms and complications such as pneumonia and ARDS, but also that quite a number of patients had other organ manifestations such as cardiac involvement, including acute coronary syndromes, arrhythmias, cardiomyopathies, and heart failure. Also, all patients with underlying comorbidities, such as pre-existing cardiovascular disease, was at particular risk, together with those with obesity and diabetes. Diseases we know have dysbiosis and leaky gut, which will be interesting in this context. Next slide, please. So many pathways are linked to the cardiac involvement in SARS-CoV, including general systemic hyperinflammation that can affect the heart, probably direct myocardial injury from the virus itself, and also, of course, hypoxemia due to the respiratory failure. Next slide, please. But another pathway could also be through gut involvement. Many studies have showed gastrointestinal symptoms, and this meta-analysis show that quite a few patients experience nausea, anorexia, diarrhea, and abdominal pain. Next slide, please. This may not be surprising, as ACE2, which is the receptor for SARS-CoV-2, is highly expressed also in the gastrointestinal tract, and that active replication has been shown in gut enterocytes. Also, diarrhea and the presence of viral RNA in stool has been associated with the disease severity and the risk of being admitted to an intensive care unit. Next slide, please. So, next. Okay, next, yeah, thank you, that's fine. We know that the ACE2 is a SARS-CoV receptor, but ACE2 works also as a counterbalance in cardiovascular, renal, and respiratory and the gastrointestinal tract by converting angiotensin 2 into angiotensin 1,7, which has anti-inflammatory and vasodilatory effects. So one thing that during severe COVID-19, when you're very sick with that, ACE2 is down-regulated, and then you get more of angiotensin 2 and less of angiotensin 1,7. Also, ACE2 is highly expressed on the luminal surfaces of the epithelial cells, and long before this pandemic, it's been shown to regulate intestinal amino acid transport, including tryptophan, which we know is associated with mucosal immunity. It's also impacting gut microbiota and has been shown to be important in maintaining gut integrity. Next. So, therefore, it's hypothesized that SARS-CoV can promote a leaky gut through down-regulating the ACE2 receptor in the intestines. And when we see an attenuated ACE2 effect, this can promote local inflammation in the gut, dysbiosis, and leakage of bacterial products such as LPS, which can affect systemic inflammation. Next slide, please. So a few words on the NLRP3 inflammasome, which many of you probably know. Inflammasomes are intracellular multi-protein complexes in innate immune cells. And it's detecting pathogenic and sterile stressors. And this leads to the release of highly pro-inflammatory cytokines such as IL-1 beta and IL-1 18. The activation of the inflammasomes typically involve two signals. A signal 1 from a PAMP, a pathogen such as SARS-CoV or LPS, and a signal 2, a DAMP, such as which is a sterile stressor from the host itself, such as ATP from damaged tissue. And this pathway has been increasingly studied in many different diseases, and it's the main important pathway in hyperinflammatory syndromes, such as we can see in severe COVID-19. Next slide, please. The NLRP3 inflammasome is also, and IL-1 beta and IL-18 is also highly involved in cardiovascular pathogenesis, including atherosclerosis, myocardial infarction, remodeling, and infectious myocardial diseases. To measure this activity, we can measure IL-1 and IL-18 in circulation, and also these cytokines are highly regulated by other compounds such as IL-1 beta receptor antagonist, IL-1RA, and IL-18 binding protein, which we have measured in our study. The next slide, please. So while we were analyzing the results for this paper, Tom Hemming Carlsen and his collaborators published a large GWAS study with COVID-19 patients with severe disease. And one of the findings was a peak at the chromosome locus involving, among other genes, the CCR9 gene, which encodes the CCR9 receptor. And it happens that the CCR9 receptor is a gut T-cell chemokine receptor, and it's associated with the homing of lymphocytes to the small intestine and colon, and it is associated with intestinal inflammatory conditions. So, the soluble ligand for this receptor is CCL25. Lymphopenia is a hallmark of severe COVID-19 disease. So we wanted to see if CCL25, look at CCL25 in our cohort to see if it was associated with gut leakage or inflammation. Next slide, please. So moving on to present our study, the Norwegian SARS-CoV-2 study is an observational study from Oslo University Hospital in Drammen, Vestre Viken. And we had material from 40 hospitalized patients with PCR-confirmed COVID-19. There was no intervention, just observation, and we had 31 patients at baseline, 23 patients day 3 to 5, and 19 patients at day 7 to 10. We also included 16 healthy controls. Next slide, please. So in this cohort, we wanted to examine a possible gut-heart axis in patients with COVID-19 and cardiac involvement. And due to hygiene, due to infection control, echocardiography was not performed in hardly any of these patients. We needed a surrogate marker for cardiac involvement and decided to use elevated troponin and or proBNP over age or gender-related cutoffs. As a marker of gut involvement, we used the LPS binding protein LBP and IFAB. Next slide, please. So, oops, this was very unclear, but I can just tell you some of the baseline characteristics in our cohort. We had 39 patients, 26% were women, and the mean age was 61 years. 22 patients, next, and then you can get the rings. Next slide. Yeah. 22 patients had cardiac involvement according to our definition, and 17 patients had not. The groups were quite similar, but the cardiac group had significantly higher levels of leukocytes, neutrophils, and CRP. And of note, the PF ratio and as a measure of respiratory failure did not differ between the groups, and there was no significant difference between the groups as to whether they had known cardiovascular disease prior to being sick with COVID-19. Next. Next. So these slides show some of our results. This slide shows the temporal course of the different markers analyzed, and the reds are the ones with cardiac involvement and the blue, the ones without. The gray line is the healthy controls. So we found LBP to be elevated in those with cardiac involvement throughout the hospital stay, but there was no difference between the groups for CCL25 or IFAB. On line 2, we see the markers for inflammasome activation, and IL-18 and IL-18 binding protein was significantly higher in the cardiac group. There was no difference in IL-1RA or IL-1 beta. Next slide, please. So next, we examined the association between gut markers and inflammasome activation over time using a mixed model, and we found LBP to associate with IL-18 and IL-1RA. Next slide, please. So, to sum up, we believe our findings support the hypothesis of gut involvement in COVID-19 patients, and that microbial translocation possibly can trigger innate immunity and systemic inflammation, which again could affect the heart. Of course, this is just an hypothesis, and no causality is proven, so more studies are needed. Thank you for your attention.